thank you, Dr. Madam, for inviting me here. Special thanks to Raj Singer because I love this place. I'm the same place where we are standing. We have played. I'm happy. My childhood friend, but he's senior to me. Dr. Muthiah Sam was here. He also used to come and play with us. And I fondly remember his father teaching me the parts of the eye, and I used to rattle at the age of 5, cornea and interval, pupillitis like that without knowing the meaning. He used to take me on rounds. I used to put torch for the patients. And since I was so involved, I also used, my father used to use the hand direct ophthalmoscope, which now I say it's not an ophthalmologist instrument. And I used to use the ophthalmoscope to see the dog's retina. Now, my first friend I saw for the Vitreo because of the epidural reflex. So I always daily start my day thanking my mother, father, who also lived to the same quarter, 10 Marshall Road at time. And his father, that my grandfather, Dr.S.Natarajan, also was here between 1930 and 1940. He went to Madurai in 1941 and he was senior to Dr. G. Venkateswamy. And my guru, whatever I am today, is because of them. Even though he is no more, but he is living in my mind and soul. And that's my friend, Sina Kusila Boi. I'm a Redmi fan. So that movie says, Mata Pita Guru Mitra Deva. That means you have to have a friend who will be not only a friend. So Guru says that if a friend has to be there, he should be constantly criticizing you so that you do well. And that's what he makes me do a rope walk daily. And I keep joking, I do many things which he keeps correcting me. Even though I go to a flat state and tell that's what I go to disco, I dance, but I won't drink, I don't eat, and I don't smoke. So I think I only dance. So I'm thankful for he told me that instead of knowing about my motivation, that they want to know about the Vitreo Society, and I want to say I made this 3 past, present, and the future. So these are the heroes of Vitreo Society which we are going to discuss. And anybody knows who did the first vitrectomy in the world? I want to volunteer. Come on, I can't keep on talking like this. Otherwise I'll go to sleep. So who did the first vitrectomy? Any first year postgraduate? Can you put your hand that is first year postgraduate? Don't get up. Just put your hands up, no? There is no first year ophthalmology student here. No, first year DO or the MS, they are not here. What second year? The water vehicle, whatever. That's when the which year you are? No, doctor, anyone. But who did first vitrectomy? No idea?
Robert Multimer.
Very good. So we are flat for him. But before that, proper captain is open sky vitrectomy. And then proper Pacomar, we used the machine and did this the garage and eggshell. Very good. So I think I'm going to talk on that. So Vitreo surgery, I think we have to, a lot of developments happened from 1970. 1970 was the first vitrectomy done, and the first case was the amyloidosis, for which he did the vitrectomy. And those days, they were waiting for 1 year for vitreous hemorrhage to clear, following hemorrhage from the complication, because surgical complications were high. And he used the single multifunctional probe, which is 1.7 millimeters, which is called the vitreous infusion suction cutter. And they will also designed that. I'm fortunate, I met them. So I met everybody who started vitreous surgery before 1970. And before that, one they tried, but he stopped the one of his knife for cataract. So there was an era of the external repair of retinal detachment, and the father of retinal detachment surgery is Jules Cronin. So he identified, before that they were doing the surgery blindly without knowing what is the cause of retinal detachment and how to reattach, but they were just doing surgery. And there was a doctor called the RIO-GOH who used the RIO-GOH suture, where he used the suture to tighten the eye, and sometimes it will cut through and come into the eye, and that's how the surgery was done, because they didn't know what to do. They only do bring the outer wall clearer and go right towards the right, that's how they will typically out, and that's how it's a fluorescent detachment, and that's how he thought we can do. So Jules Cronin said that if you find a retinal hole causes retinal detachment, and that causes retinal detachment. So if you seal the hole, he said that it will be reattached, and that's true. And that's why Ernest Custodies brought the technique of non-drainage laser buckling. That means they don't drain. And then came my mentor center, and I met him. He had visited our areas of Ophthalmology when Dr. J. Ram was there, one of our father, and Dr. Bajrat brought him in 1975 or something like that. And he invented the binocular indirect ophthalmoscope. Before that, Dr. Feiston in London was using it, and anybody knows who found the first xenon photobioreactor? They were talking about past here, you should know, because anybody knows the meaning of history? So I call it Thai story. There is a history channel also, which is there in the TV. I don't think all of you have seen, but everybody should know. The reason is, unless you know the history, how it is done, you can't modify the new techniques what you have. And if you don't know how things were in the past, how they will improve. So who found it Xenon? I also had the first Xenon photobioreactor in India. And same time Dr. Leonard brought one Xenon photobioreactor from US, and it was stuck in the customs for 9 months.
And that in the museum.
Right. So have you seen the museum? But who found out? He made sugar in Hessen, ESSEN, in Germany. And he waited for the sunlight, because the sunlight and lenses to concentrate, and then bring the beam into the eye and do the photobioreactor. I've seen eyes with the Xenon photobioreactor, and many times he pointed the one retina by looking at the sun using the lens, and that's why it is like the monocular ophthalmoscope, where you use the lens, condensing lens, and the light to see and Dr. Nakpan was trained there. So some fellows were trained in the 70s and 80s with Dr. Nakpan. They were using, it's called the bond scope, one monocular. So then later, Dr. Sharpsky and Feiston in London did this, made it modified and made it binocular ophthalmoscope. Anybody know who found the erect ophthalmoscope? Come on, yes. Somebody should answer it.
One
Yes. So he is the first man in the Retina Hall of Fame in 1851. One has once found the ophthalmoscope, and then after that only, and still 1930s, I think, when Golden found out, and the retinal detachment was a problem. And then Dr. Skippens modified and made a laser buckling surgery for this. Yes. So, Dr. Skippens has written 4 books and over 340 research papers. But one thing he said which has touched me, and he visited me in Bombay, and he also I visited him, and he was very impressed with that time when he came to see me. And I am that all of you should have a Bible belt. One take-home lesson from me, we should take this. We should read. I read Parsons, and then in spite of all that, we have my teacher, Dr. here. He was a very, very good teacher. He never scolded me. But I thought Satyavad is Dr. Brahman. And all these people are questioning me because I am a third generation ophthalmologist. And they want to prove that they ask some question and I don't know the answer, and they'll call me an idiot. I didn't mind. And only if you're a real idiot, you should get angry. So the era of modern surgery started with pars vitrectomy, and that was done by Robert McMahon. He did the first pars vitrectomy in 1970, and then in 1965, Paul Sibbers injected the first silicone oil, and after that, Dr. John Scott in UK did the first silicone oil in vitreoretinal surgery. What he did is, he didn't do vitrectomy. He reattached the retina by draining the fluid and injected silicone oil without vitrectomy. So that's where my second mentor, Dr. John, Dr. Ratzinger, and to put that photograph. He's my second mentor originally from Australian and from Rotterdam, and because of him, I knew everything what was developed by vitreoretinal surgery, and I was there for the detachment. Only 100% procedures were invited in Wales, Colorado vitrectomy course, where Dr. Robert McMahon and Dr. John Which retired in 96, and I was only Indian at that time who went and attended, and I'm happy. And Dr. Robert McMahon was a tough guy, and he refused to come to India. I don't know why. Rest of the people all came to India to Mumbai, and their own cost, and they supported our academics. And so I wanted to, my dream was, I was an ordinary school student, I expected the same road presentation tournament, the fantastic school. We were playing, my classmate is Dr.S.Natarajan and Dr. Agrawal was president of ENOA. We three studied together in the same campus. So we are all ordinary, and I think everybody will be an ordinary school student, not a first in. Agrawal got the ophthalmology prize. I got second, but I didn't get the prize. Doesn't matter. I think you have to prepare yourself. Just because you don't get prize, you should not be dejected. And I studied in Madras Special School, and no sports they took me because I was even 100 meters, 200, 400, football, anything we were champions. So I was not even in the 13th member of the team. And cricket I hated, so I didn't. But I didn't give up, and I started practicing when I went to Madras Medical College in the ground and in the Presidency College ground and in the beach. And I became a 10 kilometer record holder. Now I hate running, but I go to gym. And the other man who did the retinal repair was Padma Prof. He lived to 95, and he was a professor whom you should not be, because he was almost thrown out at the age of 95 from Cornell University in New York. Because after he retired, I have seen him operating at the age of 80, and he can't see, and he tells the fellow to see and do the trial. I mean, it's not done nowadays where you have to see everything and then do. But his contribution is he introduced leak of balloon, and he worked with one lady retinal surgeon. Now I think there are more women in ophthalmology and more women in retinal surgery. She is Ingrid Kreisig, who is still popularizing, which I don't like dogmas in the medicine, because you cannot your question. Feral Spoon is an authority in ophthalmic trauma in the world. He came and spent 2 days with Central 5 days in the Science Medical College where I am the MLC program. The same thing I offer. I don't mind coming every month on my own and spend the whole day with the postgraduate, provided they have time. The problem I put the sign on the same thing. They are posted in OPD or emergency OT, and hardly few come. Anyway, I don't get angry, but the point is the liver of flowing knowledge is there. I request all of you to drink it. What did we bring and what are we going to take? So we take up the knowledge, no use it. If we do it, as Rajshekhar said, not only can have any problem that we are presented, not only can treat the next generation, the old people like us. So you have to have when we started, I did the vitrectomy in 1984, thanks to Dr. Retinal. That time it was 400 cuts per minute. And now, anybody knows what is the rate, number of cuts per minute? Pardon? That's it now. I think less.
9,000 to 10,000 cuts.
We put 20,000 minutes. And also there was a lady that in this cut, now there's something like 40,000. But right now 20,000 commercially available, and all the companies are reading on and then we have all the stalwarts here, which is actually representative figures. The photos are wrong. And so this is the from where my friend, I thank Dr. Christina, who is a ophthalmologist in Romania. I requested her to prepare this presentation. She has done it, a sound picture. So Steve Chow is just retiring. He's 75 years old from Memphis. He did the revolutionary because he's a professor of aeronautical engineering and professor of ophthalmology. So Vitreo surgeon needs an engineering mind. And he was an engineer also. And same thing with my other friend Mark Coynes, who found the artificial retinal chip, which Dr. Rajshekhar mentioned. And many times I wanted to get this to India. Unfortunately, the second state company which made has gone bankrupt because it was 2 crore for one chip. And we have found out that the chip can interact in a blind eye with the optic nerve and retina, optic nerve and brain, and patient can see. But the problem is, still a lot of requirements happening. So I mentioned about Ingrid Kreisig, I mentioned Olam Pigman, who did the, apart from vitrectomy, I mentioned, any idea what else Dr. Gorak has contributed, which you are dealing daily? Anybody? Now, what did Gorak Pigman's contribution, which you are daily using in the practice here, even in GOH? RIO. He is the man who did the first intravitreal antibiotic injection. He found the dose for intravitreal antibiotic for enough time. So, and then he has got the maximum patent in ophthalmology more than anybody. He even has a patent for plastic, one part of plastic. He also on industry to found the plastic. And the other is there, as I said, each one who's from Johns Hopkins, and then from I said he originally from Serbia, later worked in Rotterdam, Netherlands, then Antwerp, and retired. So I went and spent 1 week in the last month. He lives in a place called Montenegro, in a city called Helsinki. Beautiful. One of the best surgeons was Ron Michaels. He was in Johns Hopkins, and he was to the combined surgery of this colleague does the cataract and intraocular lens, and he did the vitreoretinal surgery. And his book is available. I hope it's there in the library. And he was an amazing surgeon. I have never met him. He died at the age of 49. While operating, he collapsed. I think he had some lymphoma, and I don't know, probably that didn't get detected. So Dr. Gulapuri Rao, when he came from US to start RIO-GOH, he used to come to Dr. Retinal and meet me and Dr. Surendran to find out how to start. And that time, he used to tell, he used to come to see me and said, they all called me Nati, and he said, you have hands like Ron Michaels. And I want to meet him because I think he's written a beautiful textbook, and I have also written 2 books. You can go through it and find out. I'm not coming here to both, but I want to tell you these are the parts which we used. And then in 1987, the volume was introduced for the wide angle observation. And till that time, they were using contact lens. And Dr. Retinal used to operate from morning 8 to night 1, me as a fellow and even me as a consultant. So we all used to only maximum irrigated contact lens. That means we had to hold the contact lens and stand for hours together. And then many times, I found a technique while assisting without moving, how to sleep with using everything is dark. Instead also you can't see anything well, and that was the vitreoretinal surgery. And that's why I remember, I won't tell the name, the tutor at that time, I was doing my postgraduate year in 83. He told me, if you do vitreoretinal surgery, your life is doomed because no patient will be fixed. And I didn't realize that. I assisted thanks to Dr. T.P. Kumta at that time. He was my teacher. His son is Rajesh Gupta, who is also who was practicing in the area. So he allowed me to assist Dr. that in those days. As a postgraduate, we were not allowed to assist any visiting surgeon, and we had microscope, and nobody was allowed to use microscope. So I assisted him. He used a loop, and he used steel sutures for cataract surgery, and he did a ACTIOL, and he did the iris coil intraocular lens, and which was fascinating. And I wanted to go and learn because that time I met Dr. Rashmi, and he gave the donation, and we have the Ophthalmology Society prize for the Rashmi video. And then he told me he is a specialist in extracapsular cataract, intraocular lens implant, and a penetrating phacomathy for a corneal problem with a cataract. So I decided I should become specialized in 84, and unfortunately the operation happened. That's the Bindranwala firing in Amritsar, and that couldn't go to Amritsar to learn from Dr. Daljit Singh. So I went to Dr. Badnath and said, I don't want retina, but I want to do microsurgery. I knew him from school because of my father. He said, no, we don't have any microsurgery. Vitreous surgery and microsurgery, if you want, you can join. So I joined. I think I finished the exam, and the same evening I went to him, and he told me, you join. And then next day I went with Dr. J. Agarwal, also President Amar Agarwal's father. He also, I knew him from 1960. So he told me, he asked me, well, why don't you join? I said, no, I have already joined Chennai. No, what he told, he said, you have joined Retina, that means your life is doomed. So with this, I started vitreoretinal surgery career, including my partner was telling that Dr. I am using you, and no patient will see, why are you doing vitreoretinal surgery? But I am happy. I don't know what happened. I decided and I joined. So the key technology icon which I am going to talk is about the small gauge instruments, small gauge. And I am happy I introduced the small gauge vitrectomy in 2004 along with Mark Oman. At that time, Father Ram got the instrument, and then Mark Oman came, and they all were paid by the company. I didn't have money to pay anything, but I'm glad that they all came just because I invited them. So same thing. Anybody knows what is binocular indirect ophthalmic microscope? Do you have?
Yes,
who invented it? So this is what you have to find. And you after some time you'll have who had taken it, which should not happen. Please, I'm not looking at, you should find out. Marx Spitzness in 1987 published, and that the same thing happened. His own students did not use it in Germany. And I was the first one to use it in 1990 and popularized to the whole world. Entire America was telling, hey, that's not a good technique, man. How can you use it? Such bullshit. Like this, the Bible looks like this in the first one. I could not get that picture. In 90 I started, and the whole world looked up at me, but I didn't stop. And in 95, when they did the right surgery from Johns Hopkins to Italy, in Rome, that time it was called Vitreo Society, now it's called the American Society for Vitreo Society. They used oil to do the surgery, and then they all, even DrSNatarajan was objecting, saying that it's very expensive and bulky and everything. So I think when people resist and you find it good, whoever may be. So Tirupur, like I help all of you, I know all of you may not understand Tamil, but I tell that Tirupur, this is what I learned from Dr. He said, as an American trained man, I'm telling you, you can question me anytime. So same thing here. Anybody you have doubt, you can always talk to me. If I'm wrong, you can point out to me. So he said in that question. So Tiruvallur said that 2000 years back. Kepurul, Yadiyarvai Kepurul, Appurul, Meipurul, Kanvade Arivu. I don't know. I'm going to that, and everybody is using Google, everybody is using AI, and you should have your own thing to do. So I always tell, you can do, or you can have a love affair in the internet or in the whatever you call it. You can divorce also, but how you produce child? So you need that human touch for anything. So I think you all have to know history. Please find out from Dr. mentioned his visit to my hospital. A lot of people have visited from IT. It's not for boasting, I'm telling. Ours is a river of flowing river of knowledge. Everybody can come and take what you want. And there are a lot of students who have surpassed me in practice because they have taken my patients also. I don't worry about it. Not it's a fact. But I don't worry. Why I'm saying I don't keep anything because I don't want to for production. No. Whenever new technique is being done at the post-graduate and monocular degree, the assistant surgeon will not take us to the OT. They'll give some work and then they'll go to them come. And I went to 83 collecting money from friends where my father refused to give. And I was posted in GC Nasiman's unit of DC Nasiman, Professor. And I went to Dr.S.Natarajan. And I served as the assistant professor in Enrajan's unit. And then we got ACC. Next day, I came and I told her, luckily Dr. Natarajan allowed us. But anyway, said no, because all critical material was there next day. He said, what type of surgery you learned and came. But anyway, I'm happy. Those teachers allowed me, and I refused to work in my father's unit because all the time he was, even though he thought he was motivating. Fortunately, I did not get demotivated. Because he'll ask me one question like this and told an answer, he'll say you'll fail. What is the use? So I leave the house at 6:30 in the morning before he comes for breakfast, so that I can't make him do for exam. And I'm happy that I used the I used a lot of new things in that. Protect me, and even I brought the perfluorocarbon liquid to India first, and many things. And so the main thing is minimally invasive surgical era. I'm happy we used 20K instrument for long, and before 20K, Dr. Memberman Sami, Dr. Nashpal, and Dr. Zant also used indirect ophthalmoscope and do vitrectomy. That means you hold the lens in the pen and do the probe. And the problem is when you remove the probe, the infusion of the comes, the cardiac will go like that. So it's a terrible thing, and it's a shaky kind, a furniture cataract will happen. So we have from that era, we have come, and I remember sometimes I used to get the 5th 14th, right? So that time they had another scientific microscope. So one level to pull the mile. So whatever instrument you get instead of roughly, you can operate. And in that time, government of Santa had a Zeiss microscope in 1983, and don't know who was the chief at the time, but he had to take it around. And somehow nobody was allowed to use. So people used to stand and operate cataract in that test, and in the microscope also. So when I went to Chennai, it was going from somewhere to like an alien I felt, but I'm happy I learned microsurgery from Padma. And those days, Padma was doing vitrectomy using a microscope, and clear buckling with a loop. And I don't know what is the point having microscope and using loop. So I converted every ophthalmic surgery, including hernia, including dyeing the muscle, the buckling, everything under microscope. Only mistake I did, I didn't publish that time. I published only in the local newsletter. So my suggestion, I was editor of Ophthalmology. Before that it was publish or perish. But now I say publish and flourish. That means patients will read your article then come. And it's true. And then these are the people who did the first microsurgery for the 25 gauge they started, EG21. And then Dr. Yasutano, he was my good friend, unfortunately he died at the age of 65. His assistant professor at that time was Yusuke Ushima, who introduced the 27 gauge. And class A fact, after 25, he felt that 25 is very flimsy, because the metal was flimsy, so he introduced 23 gauge. And me and Class A have worked together with Dr. GOH to learn, and then now Dr. Class A has retired, I'm still continuing, and Dr. Hideho, who did the child illumination, it was like illuminating the whole bubble just with one light. The same thing you can do with the which is heavy, and now I can put 4 chandeliers also. It's like a floodlight of a stadium, so you can operate. And now we're using the 3D, which I touched upon, where you can reduce the illuminations and still have a beautiful video to demonstrate to the people. And my professors in America, they don't want to use it, because whatever it is, everybody can see what you're doing. And it's so well done. So you have the 25 gauge, the Trocar camera system, self-leading phlebotomy, and the chandelier illumination. And then the precision era, everything in ophthalmology is precision. So I have a motivation talk, 5 P's, prayer, patience, precision, and precision I made because of I'm a veteran surgeon. This I followed from the Shanta and the TAM scheme, who my friend also, and the persistence and passion. So I think the passion, if you have nothing in that hard work. So I don't like the word do hard work, but then only can come up with life. Probably I enjoy my work, so it's not hard work. If you enjoy studying, how can it be hard? Only problem is if you are not enjoying, then it becomes less hard work. So main thing is that now, as I said, we are in 20,000 cuts, and every time we start talking, the most advanced thing happening in medicine is more not in radiology but in ophthalmology. And they use first in ophthalmology, the minimal, even though keyhole surgery came in laparoscopy, I used the smallest keyhole surgery in the body that nobody had, 27 gauge vitrectomy with all 27 gauge instrument. You can even inject silicone oil, and next day I would look like as though I have not touched it. So every day I joke with the patient, I really operated, man, the eye looks so good, and but you can check the retina is attached now. So this is the again the way these people worked on. And right now they use education and private practice in Osaka and Japan, Freitas Talmans in Belgium, from Auditorium, who detected anti-VEGF therapy, advancing, and Clark Takeout I mentioned. He also introduced the 27 gauge lot of instruments. It's very good to be a friend with an engineer, and his friend was the Rich Feinfinkel, who started the Doc company, and then he assisted Dr. John White, and whatever idea he had, he did it. And then Mark D. Smith, all the robotic veteran surgery, is my good friend. He sold his rights to the size now. Earlier it was a company called Precise, and I hope to bring the, they are not selling, they are afraid that the India will do that, the thing called industrial epigenetic. You know what I mean? That's the No, they think that you will take the equipment, we'll open up the equipment, copy it. I said, come on here, who's going to buy it? But anyway, I said that I cannot really, I'm fighting out, I'm trying to do a thing. And Emily Chu is in the National Institute of Health. And these are the various methods we did. Clear buckling, the external approach for the 1950s to 80s and 70s, the 20 gauge vitrectomy. I did before that was the 1.7 whisk cutter, and then 20 gauge came. We all used for 20 gauge until 2004. And so I started in 1990. So I always had that. So I remember Vadanath was worried about cost, and Dr. John was worried about nurses questioning, because nurses will say how many equipments we can keep. So he didn't buy. So I decided that my only bad habit is to buy the latest technology or latest toys. We call it in vitreous surgery, and I had everything. And 2010 we had the 27K. And Dr. mentioned that I am a founding member of the Vitreo Society. This is a constitution. And in 1987, myself and Wilna wanted to start, and unfortunately we could not. And then 92 we started it. And that's the reason I quote Swami Vivekananda. He said the take up one idea, make that one idea part of your body, mind, muscle, and leave every other idea. And that's the way spiritual giants are produced. And you have the Vivekananda Rock in Tamil Nadu. Every year I go, I spend 3 days, I meditate. The reason is I was born. I follow Swami Vivekananda from childhood, and in my father's car, I remember the Manohar MSX 10873. The car. So he used to have arise away, stop not until you reach the goal. And Swami Chinmayananda I met I was a college general secretary in 1977. And he came, he told, you should always keep the goal post the farther. That means if you want to reach the ceiling, you aim at sky. So that's what he mentioned. If you want to do BA, you should aim MA. If you want to do MA, you aim at PhD. So that's why my goal post keep on stretching. So BA surgery is my passion, and I only breathe in and breathe ophthalmology, and that's why I am going to be 68 this month. But I decided next 32 years, if I live, I will work only for ophthalmology, and I will teach anybody who wants to come. And you don't have to pay me anything. You have to take whatever I have. So spiritual bhakti, as I said, and in the forgotten technology, unfortunately, and this is what I mentioned in when I went to American Academy. I still consider spiritual bhakti as an excellent surgical technique for retinal detachment. My philosophy that every retinal detachment should be treated to the fluid perfusion with or without protecting, and young myopic fake individuals are especially good candidates for spiritual bhakti with a good long outcome. Anybody knows why? Anybody knows that why I am telling that young myopic fake individuals are good with the get the thing you have is product retinal detachment. Any idea? With all the modern vitreous surgeons want to vitrectomy or anything, which is I hate it because the vitreous surgery, I remember Dr. Max Paul used to tell you ought to be either like a touch of pregnancy in a virgin girl. So he said vitreous loss is the problem of cataract surgery, but the main thing is there's no PPD in that. So doing a vitrectomy in an eye without PPD is a problem, and that's what I faced and catch me when I did it. So even for a young actress, I do a spinal buckling, and it does not produce any complications like the spin or a double vision. But I have a patient who has a double vision now. Because the guards say no patient will get error power. So this is what I did, and this is my technique which I modified. So I was an implant surgeon. Charles Stevens did the arterial flap like this and made the entire muscle in the implant, and the others did. So I did this. I do the small like a 25 flat, and then do the drainage. And if you do the drainage like this, the retina will settle beautifully. So the retina will be attached, and then you can check with the indirect ophthalmos flow. And then so this is my modification of external and subretinal fluid drainage. And sometimes even when combining with vitrectomy, I do that. And this is the again how I do the vitreous surgery using the both. So every surgery, Bernard used to say that the surgeon's hand should be like the Bharatanatyam dancer's hand under the microscope. And he always thinks if you give the instrument wrong, you take the thing and you hit your hand and say, you don't come like a devil, you say. So I think all the lessons I learned was fantastic. And this is what I do. Every patient I do a clear flap, so no sutures, and I do the between the clear palm side part, the 240 band, so that you have no suture. So I have done the sutureless neurobuckling surgery, and I also done suture, that's with cataract with intraocular lens with the vitrectomy. So you can see there's taking the fluid, and I simultaneously inject air into the vitreous cavity, so that and you can see I placed the 280 band. And we have all taken the implant surgeon, now we are doing explant. And you can see in the vitrectomy, you can see the time and use the liquid and drain the whatever residual fluid. And then I also do the laser, and then depending on what is the problem, you can decide what to do. And this is the pre-operative picture of a retinal detachment and a post-operative picture from hand motion to 6-18. Everybody feels that a macular detachment, if you do, you may not get improvement, but you should attempt, and many patients will improve. And the other field I worked a lot, because I was always fascinated by eye disease and prevention. As a 10-year-old boy, I used to go when my father was on duty, come to the eye hospital to use with the evening, sometimes the portwise will be done and nobody could put torchlight. So you take me, I'll put the torchlight, and in something like 10-20 patients will have corneal foreign body removed. So same thing I wanted, and then without putting drops, I went and touched the dog's eye with a needle, and because my pet dog, he didn't do anything, he did bite, but he ate me. So the trauma I do from 1984 from Chennai, thanks to Dr. He allowed me to do Vitreo Retinal from 84. Whole India, and the patients had injury or a ophthalmologist or the retinal detachment unrepairable, used to come to Dr. And sometimes he also would say no, and I take up and I do it. And myself and parents could popularize now. Any patient with an injury, they have no PLO, so you should do the surgery, but you should do it early. And I don't recommend no education, no evaluation. You have to preserve the eye, which is the most important that you can take back. However bad the eye is, even though the fear of sympathetic ophthalmia, we were removing eyes in 1980s. Now I have not removed a single eye or the fear of this sympathetic ophthalmia. So we actually, unless the eye goes in from endophthalmitis to panophthalmitis, we can no need to do evaluation. But if it is panophthalmitis, if we don't do killer septic, he may die. So we have to preserve the eye, and we should do the surgery as early as possible. So you should need a strategic thinking and individualized approach. So that's what I'm doing again and again, think again and again. What's the most suitable line of management of the given patient? All textbooks are written from the experience of the surgeon with the patient, and no written because the trauma is every day it's happening different, and now with the war injuries. So the systematic approach must have a basis in the scientific literature and genuine perspectives and no doubt mind work. I fully agree with Fell's point that surgeon must not factor on a file and analyze it, but according to a plan. So that's why Steve Charles and Michael have written 2 textbooks called Surgical Self-Education. Like a football team has a coach, he will tell they have a game plan in the night, how they will play the next morning. You should have seen this movie Chuck Day, where the Indian hockey team, the women team, that has this guy, Shah Rukh Khan was the coach. So the main thing is they are all in that plan. You don't know what is the opponent's plan, and that's what you have to study. You have your game plan, right check, plan of action, what are steps to be done. I'm very meticulous. That's why you should all go through the YouTube by acclaimed called Being Moral, and also he says why only sportsmen should have coach, surgeons should have coach. So what he did is he used to call the surgeon who was senior to him or his teacher to come back to the OT and find whatever seriously. He, Dr.S.Natarajan said in the YouTube video, he expected that my teacher cannot give any more suggestion to improve. But he said he gave me 10-page report on one surgery, right from draping to everything. He said you can do this to save the time, or you can do this to save the infection. I mean, amazing. So you need a coach. So I get all my colleagues from all over the world to be inside my operation theatre and ask them to give suggestion, and I also visit operation theatre even today to see. So the timing of vitrectomy will be immediate if you have all this complication, particularly foreign body retinal detachment. And again, this is the old study published in 1999, but nowadays we don't wait. We want to do the surgery on the immediate, and then we do the second surgery within 3 to 4 days. The first 100 hours are important, but I am suggesting any patient, with some doctors there, nothing can be done from the first day. Please refer to me in Bombay. I will take care. Fortunately, we are charitable. We will take care if they don't have money. So this is a video which I will show, which I operated in Kashmir, or it comes with foreign body, where with the pellet or the foreign body, you can see the pellet hit the eye in one part. That's a red mold you are seeing, and then the fell down. So the pellet fell within the vitreous damage. You can see the vitreous wound also, and then so that's why you should know the history. And in this case, you don't know where it is, and you have to make sure that what you're doing, everything should be very visual. So you can see the 4-prong forceps designed by myself, Dr. Manish Pape from Nastic, and Dr. Mayak Shanmugam from Shankara Hospital, Bangalore. So this is one of the best forceps now made by Epsilon and no financial interest. And they wrote the main provide this one. And so this is all the foreign body. You can see it's a 80K. Change of lens there on the lens surface, but these are all young, 15 to 21 years. So if the lens is good, we don't have to do the. So this is a chromatic retinal tactic with a large foreign body. You can see there is a total retinal detachment, and then you do the vitreoretinal surgery to release all the fraction, and then you also dissect the. So this is where once upon a time. We are now using the petrocarbon liquids. You can see the retina getting attached. You can see the foreign body. This is now being broken using the PFL. And again, there's a glass foreign body. And if you don't know how to use PFL, the glass foreign body can go to the side and produce problem. Here I use the viscoelastic on the posterior of the cornea. So yeah, ambidextrous side is what the right hand and left hand should do, and what the left hand. So you can see such a large piece, and then I will again continue. You can see the another PFCL. I do the endolaser, and where the impact happened, the large tear. So in these sort of eyes, now this is like 3,000 cells to oil. You can see the corneal OUSA suture, and then I'm doing the subtene on this one. And you can do once you remove the oil. You can also use heavy oil in case there is a recurrent media. Otherwise, you can also do a year later the eye is stable, so you can do a secondary implant. And then I introduce the 3D, which is surgery, and again, and the main thing is the beautiful book showing how the idea of the vitrectomy is to surgically remove the vitreous blood, do endolaser for the rest of the retina and reattach the pantula. And the first concern is the visualization. If you read the vitreous microsurgery by Dr. Jonovich, he said in the preface, vitreous surgery did not develop till 1980s, late 80s, because the vitreous cavity was dark and nothing can be seen behind. And the same thing happened when we underwent the bending over for vitreous, but they could not. So they could not take advantage, and again no financial interest. I use all the type of 3D. The main thing is that digital assistant, and I have a high definition camera, so 3D glasses. And this is mainly, if you combine with chandelier illumination, you have an excellent visualization. And advantages is there in anchor segment. Even though I have the 3D in my microscope, my other surgeons are not using. But you can do a 3D recording of the same surgery. But I have 3D. I do including buccal removal or buccal or anything under the 3D only. And then this is I like Swami Vivekananda, so I have made a OD that's like him, and that's OD. So it's for a main thing is that this is a 54-year with the effective vision in the right eye, and you can see the pre-op with the beta family. And I do a sort of a gate part and a vitrectomy where the fakey eye, the sort of fakey eye. And you can see the trans, having trans still entry to the wood 25 gauge system, and there is no valve with this, so you can perform the 3D vitrectomy, and the big here you have a 3D screen and 3D glasses. But the main advantage is you can see when you magnify, you will be able to see the everything what you are doing, and that's advantage. And then you can do the all the procedures under that, and then you can say I'm using the steroid to stain the uncut vitreous, and then that's another thing. So we call it chromovitrectomy. You can use the methylene blue, the brilliant so many things. And now you can see the surface is started with the cut of the steroid, and we can clear it. And then after that we can do the end of the photocoagulation, so that we can make sure that when attached. And here I'm using the retinal brush. The retinal brush was introduced by Jonovich in 1986, and thanks to Dr. Natarajan, he got it in 86 itself. So I was the first one to use the dark instruments, including retinal brush. Even the endolaser, Dr. Natarajan brought it, but I used it first. So amazing teacher he was. I mean, he told me what you want to do, you have been good for the patient. So here I'm doing a PFCL, air exchange, and that's the advantage of the wide angle. When you are doing, you don't lose your vision. I remember, I won't tell the name again, a surgeon in Chennai used to inject air, you'll be multiple frogs, right? And you will not see the retina, so inject air. But now we have technology, Charles Stephen explained that if you use it moves what do you call the air. You can see under air also. This is a beautiful view. Use the PS layer, use the proportional mode, and then remove dissect the membrane. So you need it's a back-breaking surgery. That's why, as a Vitreo surgeon, you can see here I'm doing bimanual, where one hand I'm using the forceps, holding the membrane, and I'm using the curve, which is again designed by Dr. Jovanovic, class same part. And then you can see I'm using the dissecting the bimanual Vitreo surgery, and then under the air partly and GFGF so that the bleeding does not happen. And nowadays we can use the anti-VEGF, we are sure you're going to operate, and then I'm using a PFCL foil exchange. And this is a picture, the patient we didn't have counting with a 2 meter, but with an attached macula. And this is a 3D in the OT, and this is again another brand that product that company with a combined treatment attachment. Combined treatment attachment is a patient has the traction attachment. The office is clean up. And so this is the procedure I'm doing, where you are trying to engage carpinopectomy with the perforator liquid. You get the never plan, and you have to change the plan as you go. And you can see the terrible eye, where you see the retinal so bad. And definitely I don't even guarantee for any patient, and I don't call any surgery simple. And I always tell the patient that you may not see. So I have a consent form which says with a surgery for a possibility of improvement, there is no possibility of improvement, and there is a possibility of deterioration. And particularly in diabetic eye, it doesn't it's like touching putting your hand in the fire, because you can get burned, you can get painful neovascular glaucoma. But fortunately, because of anti-VEGF, laser, and silicone oil, steroids, you don't see neovascular glaucoma. Otherwise, if I will use retinol or alcohol for the painful blind eye or diabetic retinopathy, now we can do surgery, and you can see I'm using perforator liquid to reattach the retina. And because there's a retinal element, you have to make sure you do laser and then do the silicone oil, and so you can see now I'm cutting out the membrane which has been removed. So again I'm using the retinal brush, going into the subretinal space, doing endodrainage, checking the state. You can see I've diagnosed the edges of the tear, and then I do a endodrainage through the retinal break and reattach the retina. The reason I'm doing it bit by bit is because if the retina, all membranes are not removed, and if the fraction is not removed, again it will produce detachment. That's the reason I'm doing this. So I do have ACF oil vaccine. So at conclusion, you can see a large retinal break. I'm doing endolaser post-circulation for the retinal break, and multiple breaks were there. So the idea is if you remove traction, and if you do good laser and have the silicone oil, see a number of codes I've used for putting instruments, propeller, chandelier, everything I did. And nothing after that, the eye will look quiet, and next day maybe the eye looks white also. So I think so this was the photograph 636 vision with silicone oil and produced, and then the thumb membranes inferior to the arcade, but I didn't worry about it. So again, this is a twin chandelier which after K-cut, as you can see, I illuminate the entire chest cavity with a tube light, and then use the forceps and scissor and cut it. And this is the whole idea is to release the traction. And then, so the main thing is that any complicated patient we can do, but does not mean that, so this is my operation theatre. Everybody will have a 3D class and watch what I am doing and can ask me any question. Even under local, sometimes the patient will ask me something, I am not talking to her. So I make an agreement, because the patient can sue you particularly in Mumbai or in abroad. Then very long waiting, he is talking, but I tell the patient, I will talk. If you mind, then I will not try to shut up better than. And they allow me, so I do that. So this was done by. So this is again a 3-month baby ROP surgery, where I was shown with the surgery where. So this is, you can see the eye is sort of small, and you have to have that. So that's why your hands should be delicate, and you can see I'm using the 27 plus instrument for this. You can see I'm going to the past bracket approach for the surgery for the ROP. So you can see there's a traction from the disc to the periphery because the patient probably came late and did not undergo laser. And then I remove the vitreous privilege. So the idea is to release the traction, anterior-posterior and the tangential, and then release all the traction. You can see, and there is some bleeding, but you can control it. You cannot keep the intraocular pressure high because the optic disc you have to all the time monitor. But you can see, and I'm continuously doing back and forth. Now under the PFCL, I'm doing the post membrane removal, and you can see this is where I want to have ophthalmology where tactile sensation is touching with the hand. So general surgeons can do, but I can't do. So in vitreous surgery and laparoscopy, we don't have that. So I don't know how to explain to a patient or to a fellow or a surgeon, but that's what I'm learning, how the retina will feel when you're using the forceps, you're not touching with your hand. And you can see I'm now using the, finally I used anti-venom, and this is the 27 gauge, and I got it fatigue, release the traction, and the patient so I introduced the endoscope for the first time in India, preferential hyperactivity perimeter, and many things. The idea not to boast, I want to say we are nowhere inferior to the rest of the world, and I should say we are more advanced in some things, more than whether it's America or Europe. And we also had the biome, as I said, now we have volume 6 coming. I also published this, the fact that somehow nobody buying this and nobody making it. A curved vitreous cutter where we can go it in the phakic eye and do the peripheral basic vision. I designed 4 steps to remove the black body. And this is I call it a Maharaja chair, which I designed so that I keep the patient's head little ahead. You can see the pointer here. So the patient's head is little out so that the surgeon will not bend down. And the chair will, and I put Dr. Charles Stevens came to my OT in 93 and said, your cushion is so thin, if you operate for 3 hours on patient, you'll have back problem. It will pain. As an old man, I'm telling you, if anybody like to come without moving, he will have severe back pain. So please put cushions. So I have put a 4 inches cushion for a patient. I used to lie down and check. When it becomes old, I change it. And I designed this chair, plastic from 90 I'm using. I call it Maharaja chair. I tried patenting with the Ophthalmology, could not do it anyhow. Now I'm not interested in patent, but I want people to use how I employed a VR surgeon from Arvind Hospital. And he said that he's not comfortable with it. I said, okay, why, what do you like? I went and operated and asked the 3 patients there, but without practice I have problems. So I designed the practice, which will go front and back. I designed on the shoulder weight, will go to the elbow. At the elbow weight will go on the thing. So my hand, I have the bone. So I kept a cushion on my handle, and the handle will go towards me, so that only the lumbricus will work. And I hope you remember the lumbricus, and that's made for the surgeon. And that's why we have the fine surgery. When we used the instruments were very heavy, and even the chant, the magnets I've used here, and then we have used the magnet. So now we use 27 gauge, so that the instrument should be less than 5 gap, so that you don't get tremor. And they are trying to use robot for being robotic surgery. So, and present and future technology offers better care for patients and doctors as well. So we should not lose our health by doing surgery. So I remember they have done a study, I don't know whether I see that the vitreoretinal surgeon, when they do a membrane feeding or using an IMM feeding, they don't blink, and because of that they have dry eye syndrome, and that's because they are worried. They can't think. I keep talking, I do like surgery, I do anything. So you have to blink normally. So they have studied that. So you have to have a better position, better visualization, improved performance for what? For the patient to see and better results. So and this is again thanks to the Apostami, they have made and this rigidity is from Alcon, and then we have the Apostami to the 3D. And then this is a beautiful microscope, not available still. We call it electrical visualization data called operative room board, like a robot. It's called the optics. The patient's, the idiot's father has a macular standard disease and he has 660 vision. They started a company to make a lotion aid and then will come out with this microscope. I don't know, they're not called a tool, and that's the OR board microscope. They also come out with the lens, contact lens, as well stereo depth and an 8K monitor. I don't know if anybody ever seen the 8K video, beautiful visual. And this is the Aptar microscope. You can see you can magnify something like the lens to 2300 to 400. And then it's amazing. I mean, I used it in Frankfurt, but in Hong Kong. Now this is a C1 which we have kept in our foundation hospital, where in the regular 3D from NGT or Zeit, you look this way and operate. Here you can directly see whether see blue, multiply outward, but from that for the people they used it. And this is the C1 which now I use and they are not got it. So I go and teach all over the world, and this is the Vitreo school in Greece, and that's where I got learn. And you can see that you can see directly and operate. So you can see that this is all the 3D class, you see double vision, but you can see that this is all I use. Somebody took a photograph and said, see my pictures and the main flow because of the doing my, I think I've done about 65,000 visual surgery, and I still like to do, and surgery is meditation for me. So this is the 3D, which is the latest one, and I'm happy we have in Mumbai now. I have not bought it. One day we have. This is another one, DRB, which is a deep reality viewer. They use for watches to examine the macro thing, but now it's the main where you can see like this. You can see the object, both 3D glass, and directly you can see 3D visualization. And you have Dr. Cruz, who is the chief editor studying in more fields, and Yannick Schlemmer was the president of Boarding Club. So they all have visited Mumbai. Yes. So you can see that you have a 3D view without a 3D class.
How
But not
you will I
So I'm a teacher in all the residential schools. So my dream is I want students from RIO to come and observe me, learn whatever you want, and please excel me. And Rajshekhar was talking about gene therapy. The history is going on from 94. One important thing I want to tell you, when my father became the superintendent of government ophthalmic hospital in 1984, he started the first genetic clinic as a specialty clinic here, and Dr. Ratna Sabapati, I think, was the professor from that time Karamadi, and he appointed Dr. Kumar Manigal to do the genetic clinic in the same hospital. So I'm glad to work again. I'm trying to get international grants to do the gene, not gene therapy now, but at least to do a genomic. That means you should do a phenotype and a genotype. That means you do the fundus photo, OCT, ERT, and have a clinical diagnosis as a RT and what type of RT, and then do a genetic test and find out whether it is a corneal dystrophy or RP or RP65 mutation. Then you know which type of gene therapy will work. So this is how gene therapy works. It can be just a simple replacement to editing. I'm not going into the teacher. They take all these routes. And then now they are trying to do it in the subretinal space. That's where you need vitreoretinal surgeon. And that's why I'm working on gene therapy for long. One day I will do it. I'm not the first to do. But at least when it's approved in Europe and the next week I want it in Mumbai, I hope I will do that. And or if they say they want a government hospital, I will prefer RIO to be the first one to use it. And this is the various approaches which I'm saying. I'm not going into the detail. I want to tell you, you can do it in this hospital one day. And these are the things going on all over the world. Intravitreal was easier, but you know everybody is doing intravitreal injection. But unfortunately, it's not working. So I'm happy. So then we did a complicated, complex surgery, so I have to do the surgery.
you should please with the hospital.
So this is Dr.S.Natarajan. He is my friend. He is in UK. So doing the, he is there in the YouTube as how the vitreoretinal surgery is done. So there is a gene therapy going on. The problem is, he is Robert McLaren. And then you can see, we need a modern and so he will genetically modify it, so that's why it's called personalized medicine.
From the house we give them, but we start like Korean Indian.
They're doing for quality. So you can see they use the platform. And I'm happy when I went to Portugal, I got them for use in the 90s. So you can see this is the subretinal injection which we are using, and you have to go with the subretinal spray. So the other is
What are the ribs and the you was supposed to know your breath none.
so they say that you cannot breathe, so they are some using the gene replacement. And the main idea is to deliver the gene in the subretinal space. If you buy the Luxturna pamphlet, they say it's the subretinal injection. No, you have to do a vitreoretinal surgery to do all this. I don't know. They all commercial people want to make it like a gimmick, and they want it a subretinal injection because the cost of one subretinal injection is 4 crore. So they want the insurance to pay, so they call it a subretinal injection. So, and this is the first FDA of the Luxturna, which can be used. And my friend, Dr.S.Natarajan, she was from Padma Shri Prof, the family. Now she was adopted by the Dutch people, and she lives in Ghent. And she is the one first robotic surgery she has done for Luxturna. We checked in the, and I'm happy. I told her you should visit Madras and give a talk, and she's going to come. And then the retina is the ideal target, so I'm very happy it's in my field. And these are the application of gene therapy for retinitis pigmentosa, inherited retinal dystrophy, Leber's atrophy, age-related macular degeneration, choroideremia, achromatopsia, acclaimed retinostasis, startup disease. I'm sure you're seeing daily OPD. Please don't tell the patient nothing can be done. Tell something, talk to them. Some postgraduate should take as a role of counselor, it will help you. Because one day things is going to come. And that Charles Stevens said this and put it in the Stevens Research Institute. Never say never again to a patient. I add one more thing. Don't be false hope, but tell the truth what is going on. So that's what I keep telling. Patients are 35 years, they're waiting for me. So I'm trying to collect 1,000 crore in the next 22 years if I do. And I'll get this to India. And if I find some the patent and money, I'll do free for our Indian patients and charge the rest of the world. Like that's what they did for this one other thing. And stem cell, unfortunately, even a lot of work is going on. Our own Dr. Rajini Bhattu is working with the company in US, but I don't know who's the one who's working in LV7 with NEI. But a lot of trials are going on all over the world, and all this has to be injected in the laboratory. Delivery and precision is important. That's why they are trying to do the. So all that main thing is we have retinal detachment, reattachment in the 70s were less than 40%, and now we want 95%. Traction detachment more than 60%. Macular closure more than 90%. Epiretinal we want more than 85%. But all this is good, but still you can see nothing is 100%. So 10 out of 100 or whatever, 15 out of 100 will not improve. So don't give a false promise to the patient. So all these advances, what all these changes mean for patient? Faster recovery, less discomfort, expanded and don't undermine their own skill. Everybody says 5 minutes, say go, no pain, go. That's what America is doing. And our own people are doing. So I think that we should not take it. How much time it takes to become a phaco surgeon? And then you can imagine how much time, even in my hands today, I have tough time to abandon sometimes. I don't abandon, but it's a tough surgery to be a tough ophthalmic surgeon. Everybody should tell how great to be an eye doctor, how great and how much difficult it is to be an eye doctor. So no ordinary person can become an eye doctor. That's what we should talk in the social gathering, in Rotary, Lions. We have a Lions member here, my friend Bala. So the main thing is reduce surgical time. I operated one patient for 7 hours. I still don't know what I was doing 70 for 7 hours. But now, I fastest vitrectomy I've done the 7 minutes, and sometimes I do it 20 minutes. Again, time is not important. Stage of says I pass. No. More important is quality, and if you are doing well, it is like somebody making a biryani. You do not need a recipe book to do a biryani. So same thing is like with surgery. It has to be in the spinal level. I can close my eyes and operate, which I can't do, and finally improve quality of life. So I'm glad I invited Dr. Ophthalmologist from Poland, and from Poland. He's a great friend. He calls me every year to operate in Poland, in Lublin. So he's got a one Proma Ophthalmic student, 60 years old, and he came in January on my father's birthday and gave an audition. And I showed him the place where they have such a big hall, not such a big, maybe a stage for And he said we can start an international training center. And then we have something of Ashrafati from, he's the greatest cornea and cataract teacher in the world. He's a soccer teacher. And I'm making a plan. They are charging something like 1,500 to 2,000 euros for a course, 1 week course. But I'm going to tell them, we charge the Europeans 2,000 euros. For India, do it in 2,000 rupees. I think happen. So all of you should come and make use of. And my second mentor, I am a trustee of this George Fellowship, where we give whoever wants to be a surgeon like Rajshekhar wants to do more, they can give 15,000 euro for 2 years to travel, learn more and come back. And then this is my father, so he always has this right. Success comes from heart, devoted and dedicated work, and I have decided to remove the heart and put work with love and passion. And I think everything, and he was born in 19 January 27 in Kulasekara. Anybody knows? Anybody from that region? Kulasekara? Nobody? Nobody from the district?
We have gone there.
Why you have gone there?
We have gone there here by anybody.
Okay. So what is the importance of Kulasekara today?
On service.
Tomorrow temple is there, but here, under here they have the best Dasara festival, they have the best Kali in the ground, all that is history. But now, today, Kulasekara is going to be an international place where the whole world is looking, because we are going to have one of the most advanced rocket launching pad next to Sri Harikota, thanks to Government of India. So anyhow, that's why my father was in 1984 to 87. He has written a lot of items, and he was the first civil surgeon to be in charge of the healthcare country, and so I was at the school, I was to bring that photos, and Dr. A.F. Ram was the superintendent at that time, and he was the ophthalmologist in our university, and he started the program. I used to put torch in the camp, and I was a volunteer, and so the man, he organized a lot of exhibition, and you can see that's the eye hospital, and that's my sister, she left, and that's my brother and me. This is taken in the eye hospital compound, and the photograph which Rajshekhar showed was taken in the quarters. So there's the MSS eye corner in Periyar Science Center. Anybody knows? Have you visited the Science Center or a planetarium? No? You all should see, man. There's a lot of ophthalmology there, because they have the illusions, and it's not related to ophthalmology, but they have physics also. And there's a Solomon with their heart corner and eye corner. Unfortunately, this year they removed it, so I went and met them. I hope to recreate again, and all of you should visit. And he wrote books, and he made a mission called Vision is Our Mission. And this is our hospital in 2004, and that's MP and MLA of our region, and my father was there. We started this in 2005 in Dharavi, and you can see my father is sitting, and he made me give a talk to the school children. And I used to hate this, because I will tell you, what will I go and talk about diabetic retinopathy to the children? He used to tell, you have to do, because you give it in their understanding. So I come and do it in the Birla Planetarium here in Adaya, where I come and teach the students. The reason is, he said that they should go home and tell the grandparents to go to Dr. Rajshekhar for retinopathy management. And that's my father and mother. So thanks to them. So he wrote that eyes that heal, hearts that serve, the deeper purpose of eye care. And this is what I want all young optometrists and young eye doctors who are here to take a lesson. And then this I said, Dr. and I did a 75th birthday anniversary. We have 2 occasions in the Retina Hall of Fame. This is not for boasting. I want all of you to know. This guy introduced perfluorocarbon liquid. This guy revolutionized the 3-port pass-pena vitrectomy called the O'Malley vitrectomy in 1976 or something. Ernest Custodius did the external scleral buckling. Jules Gordon found rectal hole. Dr. Donald Cass, whatever is described in OCT now, he did it without OCT in 1970. And this year, Dr. Donald, not Cass, let me mistake, Donald Cass, and his student, Dr. Natarajan, is getting the Natarajan operation, and she worked closely with them, and she was also telling me, the students nowadays don't remember him, and she's feeling very bad. And please read about Donald Cass, because he has done the maximum for the macula, the layers of macula, whatever you are reading, along with Paul Bird. And Paul Bird also, not Paul Bird, sorry, Paul from London. So he also gave the Natarajan operation. And anybody knows him? Albert Einstein? But what else is he is famous for? Correct, madam? He's not Switzerland, the physics in the Switzerland. Optics, correct. So the main thing is I love him because he was such a stubborn guy who got the Nobel Prize, first ophthalmologist to get a Nobel Prize in 1911. And after that, no ophthalmologist has got for ophthalmology. 3 more ophthalmologists have got for chemistry and some other thing, but not for ophthalmology. After him, I hope to become another Nobel laureate for that. And Robert McNamara for vitrectomy, Harvey Laker for balloon, Charles Keegan for modern retinal detachment surgery. Edward Norton was the teacher of McNamara and Steve Charles. And then Golem Payman, he has visited Madurai, Madras. Stephen Ryan, I don't know whether you read the book Stephen Ryan. So he is no more now. Howard Shanks, now he's become a photographer. Jerry Shields, the man authority on ocular oncology, who just recently passed away. He is John Scott, who revolutionized silicone oil in surgery, and Carl Starbuck, whom I have visited, where Starbuck was the chairman. And he, Warren Hell Holmes, who found the entire, he was the first one to get me in the Retinal Hall of Fame in 1851. So from 1851 till 2016, only 214 of retina specialists are there. I'm glad Indians are there, 2 of us. And Lawrence Zanuzzi is still living, is still working. He is my inspiration. At the age of 90, he is coming daily at 7 sharp. He has fellows working with him. Even now, I sent a mail to him asking him some question. I always wonder what, I'm a surgeon. I don't like the micropart. I remember mugging up the 10 layers of retina and going and vomiting in the exam. But I didn't understand. But I introduced the first OCT. And now I know he works on so many things under the microscope, and then Dr. Bernard. So finally, my dream is to make that line to India 2050, and we have, this was the old statistics, and now we have 101 million, that means 10.1 crore people having diabetes, and everybody has to be checked. We only have 30 to 40,000 ophthalmologists, maybe 100 postgraduates here. So my dream is use a smartphone to take good retina photographs, and rest we can deal with AI and we can prevent them from going blind. So we have to have this in the general practitioner, the endocrinologist, and this is what I say, that we can take a good photograph. I call it ABCD from the movie Prabhudeva. Anybody can screen for diabetic retinopathy. Then I introduced in 2019 as an All India president, screening to teleophthalmology for the prevention of diabetic blindness, and I gave in detail like our Prime Minister Jyotirala. So the diabetic blindness can be removed by making teleophthalmology, and we can reach every village. We have 6,47,650 villages. In my lifetime, I want to reach all of them. You don't have to go. You have to make money. You need money. You need the thinking. You can send people. You don't need doctors. We don't need nurses. You can use all the school dropouts to go and be a part of the healthcare. And so this was the AI which is being used. And then I dedicate all my achievements to my mother institution, and that is Regional Institute of Ophthalmology, Government Ophthalmic Hospital, Egmore. Sorry, emotional. So, you all have to be proud. We are the oldest eye hospital in Asia, second in the world, started in 1819. So, and we are the first and the biggest museum, Elliott School of Museum of Ophthalmology, started in 1919. Please put photographs daily in the social media. The whole world should come here, and they have to contribute, not just visit and go. And as a part of, I'm part of the All India Ophthalmic Society. I create the museum, and I'm sure Dr.S.Natarajan remembers. I put big posters in entire indoor All India Ophthalmic Society meeting of our eye hospital, and we have a lot of GOH people who have taken, and we got a replica of our Elliott School and kept it there, and we have got a museum in Delhi, and we celebrated 200 years of ophthalmology, and I still want to do. I brought the RAMSCO, the Royal Australian and New Zealand College of Ophthalmology people. They have donated something to a photograph or something. They came and visited the Elliott School. I came all the way, and then in 2019. So thanks to my 3 generations, we have done 150 years of service to the nation. My grandfather from 1930s, my father from 1955, the same complex, and I am working in this field, but as a school I worked as a volunteer in the camps. So I am happy that Padma Shri and I actually have preserved my school fees, MMC fees. Anybody has a guess how much I would have paid for my MBBS every year? Any guess? No, somebody should tell you. Imagine and ask, tell no, I'm the last slide, don't worry. Huh? Madam? Hello? Hello? 204 rupees. So every year you pay 204 rupees as a tuition fees, 28 rupees as a tuition fees. And then exam fees will be another 250 rupees. So 500 rupees we finished the year. And my father was so confused, he never bought a book. Every time he told me, you go to this classmate, his son will have, take it to this. So I'm happy, I read it, luckily I read. So thank you very much for a patient listening.
Thank you, sir, for that truly captivating and insightful lecture. We are deeply honored to have had this opportunity to benefit from your vast knowledge, expertise, and invaluable insights.